Thank you for having me to present this on behalf of all the investigators of the RECLAIM trial. The organizers asked me to discuss the two completed drug trials and not just the Ibudilast one. So I'm going to share with you on the pentoxifylline one as well. So RECOVER is the adaptive platform trial. I mean, not RECOVER. What am I talking about?
A RECLAIM trial.
Brainwashed. Anyway, the RECLAIM trial is a Canadian adaptive platform trial that was funded by CIHR and included 9 sites across 5 provinces. And this is back in 2021 when we put in the grant to apply for an interventional trial for long COVID. And at the time, WHO has these potential pathogenic mechanisms. And so on September 20th, 2021, a group of investigators, the RECLAIM investigators, patient partners, and some outside experts, and maybe a couple of you are actually here in the audience, discussed about 20 different interventions and looked at the data and also thinking about the pathogenic mechanisms as well. And basically decided on 2 that basically is targeting immune dysregulation, inflammation, and endothelial dysfunction. So the 2 drugs that were picked were really repurposed. So this is the first one, Ibudilast, which also is called the Medicinova 166 compound. It has been used in Japan for since 1989 for the treatment of asthma, and in Korea for post-stroke symptoms to improve recovery. Now, the dosage of these are 20 milligrams or 30 milligrams a day. And the mechanism of action is really by inhibiting the phosphodiesterase 3, 4, 10, and 11. And it also has MIF inhibition. And so that's the macrophage migration inhibitory factor. And it also inhibits the TLR4 or toll-like receptor 4. And this came up a couple of times with low-dose naltrexone as well. So that's partly why we picked it. The expected clinical effects has been sort of quite studied in the neurological indication. By decreasing platelet aggregation, vasodilation, by increasing cerebral blood flow, anti-inflammation, glial attenuation, and has neuroprotective effects, especially when it comes to chemokine and cytokines. So the other compound is an old drug. Some of you may remember this, pentoxifylline. It's a xanthine derivative, and it's an oral medication, 400 milligrams taken 3 times a day. And it's used for treatment of intermittent claudication for decades in sort of North America. But it has fallen out of vogue, partly because we have better treatment for claudication and occlusive vascular disease. But it's well studied because it was first approved in Europe in 1972. So again, there are systematic reviews looking at all the various effects of pentoxifylline, including decreasing inflammation, immunomodulatory effects, decreasing oxidative stress, beneficial to the respiratory system, and has other interesting beneficial clinical effects in various studies, including decreasing the blood viscosity and also improving microcirculation and tissue oxygenation. And so because we thought there's endothelial dysfunction and maybe oxygen is not getting into the tissues, we like the profile of this compound. So this is the structure of RECLAIM. So maybe slightly different from some of the other studies. We did include adults with confirmed or probable COVID-19 infection. They have to have lingering effects for 3 months or longer. But one of the difference may be that we require them to be treated with standard care therapies, symptomatic treatment prior to entry. And they have to be treated for at least 4 weeks. And at the time of entry, they have to have symptoms. And so because we have guidelines in Canada on how to treat POTS, we have guidelines on how to treat migraines and reactive airway disease if someone is coughing, and so on and so forth, depression, anxiety, etc. So that may have a bit of a different sort of group in terms of who is entering this trial. So we designed the trial to have baseline randomization and then a 2-month treatment period for these 2 drug trials. We have 4 other trials that are ongoing that are slightly different with a longer sort of intervention in some of them. But in these 2 drug trials, it's 2 months of interventions and 4 months of follow-up. And the visits and also assessments are done at baseline 1, 2, 3, and 6 months. The primary outcome, there was lots of debate as to what the right primary outcome was. And we actually tested some various sensitivity of various things, including the EQ5D5L, and thought that the SF36 may be a little bit better in performance. And so we picked the SF36 physical component score as a primary outcome. There are many secondary outcomes. I will talk about them later in the results. There is like 60 pages of how it's going to adapt and rules for sort of defining superiority trigger, inferiority trigger, and equivalence trigger, etc. I'm not going to go into that in detail, but basically it is this was designed and written into the protocol. So just want to show you a little bit about sort of our group. So the first patient entered in May 31st, 2023. It took us a while to sort of get all the ethics at all the various sites, all the contracts signed. And the last patient entered on December 20th, 2024. We have a total of 460 participants divided into Ibudilast, pentosylvine, and placebo group in a 1:1:1 randomization. Mean age and median age are very similar. They're in their late 40s and similar across the groups. I would say that they range from 18 to the late 80s. 70-something% is percent female and 80-something% white. I would say we have a fairly educated cohort. This is the percentage of some college or university education. So you can see that it's like 80-90%. Frequency of COVID infections is quite well distributed with 20 or more percent. That's around sort of 3+ infections. And the mean duration of long COVID is about 2.5 years. Now, it does vary. We have people who are about 4 months into it, and then we have people who are 4.9 years into it. So there is quite a variety. In terms of post-COVID functional scale, there's a fairly large distribution of 3 to 4 moderate to severe limitations across the groups, you can see. And because advocacy from patients wanting them to be included if they don't have a positive test, we also did sensitivity analysis around sort of COVID certainty. So actually in the group, 80-something% of participants tested positive, either by PCR test or antigen test. And the top moderate to severe symptoms, so to qualify as moderate to severe, you have to have the symptoms at least half the time, and it has to affect you moderately or severely, or very severe. And so, not surprising, fatigue comes up, and the post-exertional malaise piece comes up, and also sort of the neurocognitive piece, difficulty paying attention for long, trouble concentrating, and trouble remembering things also come up as well. So these are our results. So the black is placebo, the orange is Ibudilast, and the blue is pentoxifylline. And so on the y-axis is the mean physical component score of the SF-36. I can tell you that mean and median are very similar, so I'm presenting the mean here. And on the y-axis, it's baseline 1, 2, 3, and 6 months. And so if you recall, intervention is from baseline to 2 months. And so you can see that people improve a bit, all three groups improve a bit. From probably more so from baseline to 2 months than from 2 months to 6 months. But there was really no difference in these trajectories. And if you think about SF-36 PCS scores, a 5-point score is what we would think, an improvement in 5 points is what we would think as clinically significant. So you can see that for placebo and the pentoxifylline group that achieved that over the 6-month period. And so overall, the folks in the study improved. But if you look individually, so this is a plot on the right-hand side, just from baseline to 2 months, and looking at sort of whether they improved or not. The blue is those who improved, so they went from a score to a higher score, and the brownish lines are those who got worse. Now, there are many things in life. They can have more stress during that period. They could have another infection during that period, but this is sort of what we showed, that there are more people improved than those who actually did not improve. However, I just want to point out that if you look to see this population, so 50 is the average population sort of mean, with a 10 kind of point for standard deviation for the SF-36 PCS score. And you can see that when they start, they're all lower. They're definitely not doing well. And so we like to have a reasonable distribution around the mean, 50, but these folks are not doing well. So we also use Bayesian methodology and statistics, so similar to a prior presenter, and looked at probability of benefit. So I'm showing you about Ibudilast versus placebo, and the bottom panel is the pentoxifylline versus placebo. And usually, we like to see probability of benefit for this posterior densities of treatment effects to be above 80%. And you want to see the mean difference to be something meaningful as well. And so we failed to show that for both of these compounds. The probability of benefit was 29% for Ibudilast and 46% for pentoxifylline. And the mean difference is really not meaningful. We have many secondary outcomes, including SF-36, the mental component score, neurocognitive testing using Test My Brain. So we have 6 different tests. 6-minute walk test, the Borg-Dyspnea scale, fatigue, post-exertional malaise, and symptoms as well. And I can tell you that all of them, except for one, showed similar results, meaning they, in general, improved from baseline to 6 months, with more improvement in the first couple of months, but there's no difference between the 3 groups. So the exception is of the SF-36 mental component score, pentoxifylline versus placebo, the probability of benefit was 87%. Now, I caution sort of over-interpreting that because we did tons of tests. But I just want to show you sort of what we saw. We also did subgroup and sensitivity analysis according to age, according to sex, according to number of COVID infections, certainty of COVID infection, meaning having a positive test, wave of COVID infection, and the variant as well. So wave 1, 2, 3, 4, Omicron, and BA2. And duration of long COVID. So did you have it less than a year, 1 to 2 years, or beyond 2 years? And none of the subgroup or sensitivity analyses showed any positive results. There are many limitations to this study. It was a bit of a guess as to duration of intervention, and maybe 2 months is not quite enough. Maybe the dose of intervention, so I didn't actually tell you that Ibudilast, we use 40 milligrams a day. The reason to settle on that dose was slightly higher than the asthma or the post-stroke recovery dose, but lower than what is in trials for ALS and multiple sclerosis. Because one of the side effects of higher doses of Ibudilast is actually fatigue. And so we thought, you know what, these people are fatigued already, we don't want to make things worse, and so settled on 40 milligrams a day, so 20 twice a day. Maybe the primary outcome is not quite the right one either. Yeah, I'm done. And then we discuss about the heterogeneity of phenotype and endotype. So in conclusion, neither Ibudilast 20 milligrams twice a day or nor pentosyphline 400 milligrams 3 times a day for 2 months was effective in improving physical health-related quality of life as measured by SF-36 physical component score in individuals with long COVID. And I want to thank our participants who spent a lot of time with us, our patient partners who helped design the RECLAIM trials and ongoing as well, and the team that's at UHN, and also Medicine Nova for providing Ibudilast, and CIHR for funding, and obviously all the site PIs, co-Is, staff, and trainees as well. And I'm going to just show this because someone asked me about websites. The CAN-PCC website is on there, so several people asked me about that. That's the guideline website, and then RECLAIM is the trial, CANCOV is the observational study, and Long COVID Web is the Canadian Research Network. So thank you for your attention.